25 Most difficult, acid-base balance and advanced ABG interpretation. Question 1. A client with severe diarrhea has the following arterial blood gas, ABG, results. pH, 7.28. PaCO2, 30 mm of mercury. HCO3, 14 milliequivalent/L. How should the nurse interpret these findings? A. Uncompensated respiratory acidosis. B. Partially compensated metabolic acidosis. C. Fully compensated metabolic alkalosis. D. Partially compensated respiratory alkalosis. Correct answer, B. Partially compensated metabolic acidosis. Rationale. The pH of 7.28 indicates acidemia. The HCO3 of 14 milliequivalent/L is low, indicating a metabolic cause. The PaCO2 is also low because the lungs are attempting to compensate by increasing ventilation and eliminating CO2. Because the pH remains abnormal, compensation is partial. Why the other options are incorrect? A. Respiratory acidosis would have an elevated PaCO2, not a decreased PaCO2. C. Metabolic alkalosis would have an elevated HCO3 and an alkalotic pH. D. Respiratory alkalosis would be caused primarily by a decreased PaCO2, but here the markedly decreased HCO3 identifies the primary metabolic problem. Question 2. A client with prolonged vomiting has the following ABG results. pH, 7.51. PaCO2, 47 mm of mercury. HCO3, 35 milliequivalent/L. Which interpretation is most accurate? A. Uncompensated metabolic alkalosis. B. Partially compensated metabolic alkalosis. C. Partially compensated respiratory alkalosis. D. Fully compensated metabolic alkalosis. Correct answer. B. Partially compensated metabolic alkalosis. Rationale. The pH is elevated, indicating alkalemia. The HCO3 is elevated, identifying metabolic alkalosis as the primary disorder. The PaCO2 is elevated because the respiratory system is retaining CO2 to compensate. Since the pH remains abnormal, compensation is incomplete. Why the other options are incorrect? A. The elevated PaCO2 shows that respiratory compensation has begun. C. Respiratory alkalosis would primarily involve a decreased PaCO2. D. Full compensation requires the pH to return to the normal range. Question 3. A client with chronic obstructive pulmonary disease, COPD, has the following ABG results. pH, 7.36. PaCO2, 58 mm of mercury. HCO3, 32 milliequivalent/L. How should the nurse interpret these findings? A. Uncompensated respiratory acidosis. B. Partially compensated respiratory acidosis. C. Fully compensated respiratory acidosis. D. Fully compensated metabolic alkalosis. Correct answer, C. Fully compensated respiratory acidosis. Rationale. The PaCO2 is elevated, indicating respiratory acidosis. The HCO3 is also elevated, showing renal compensation. The pH has returned to the normal range, indicating full compensation. This is commonly seen in clients with chronic CO2 retention, such as those with COPD. Why the other options are incorrect? A. Compensation is present because HCO3 is elevated. B. Partial compensation would have an abnormal pH. D. The primary abnormality is the elevated PaCO2, making respiratory acidosis the primary disorder. Question 4. A client is hyperventilating during a severe panic attack. ABG results are pH, 7.55. PaCO2, 25 mm of mercury. HCO3, 23 milliequivalent/L. Which acid-base disorder is present? A. Respiratory alkalosis. B. Respiratory acidosis. C. Metabolic alkalosis. D. Metabolic acidosis. Correct answer, A. Respiratory alkalosis. Rationale. The pH is elevated, indicating alkalemia. The PaCO2 is significantly decreased, indicating excessive elimination of CO2 due to hyperventilation. The HCO3 remains normal, indicating that significant metabolic compensation has not occurred. Why the other options are incorrect? B. Respiratory acidosis causes an elevated PaCO2 and decreased pH. C. Metabolic alkalosis would involve an elevated HCO3. D. Metabolic acidosis would involve a decreased HCO3. Question 5. A client with diabetic ketoacidosis has these ABG results. pH, 7.18. PaCO2, 22 mm of mercury. HCO3, 8 milliequivalent/L. Which interpretation is correct? A. Uncompensated metabolic acidosis. B. Partially compensated metabolic acidosis. C. Fully compensated respiratory alkalosis. D. Mixed respiratory and metabolic acidosis. Correct answer, B. Partially compensated metabolic acidosis. Rationale. The low pH indicates acidemia. The very low HCO3 identifies metabolic acidosis. The PaCO2 is also decreased because the client is hyperventilating to eliminate CO2. Because the pH remains abnormal, compensation is partial. Why the other options are incorrect? A. Respiratory compensation is occurring, as shown by the decreased PaCO2. C. The primary abnormality is the decreased HCO3, not respiratory alkalosis. D. The low PaCO2 represents compensation rather than a separate primary respiratory disorder. Question 6. A client with persistent nasogastric suction has pH, 7.49. PaCO2, 49 mm of mercury. HCO3, 36 milliequivalent/L. Which acid-base imbalance should the nurse identify? A. Partially compensated metabolic alkalosis. B. Uncompensated metabolic alkalosis. C. Partially compensated respiratory acidosis. D. Fully compensated metabolic alkalosis. Correct answer, A. Partially compensated metabolic alkalosis. Rationale. The elevated pH indicates alkalemia. The elevated HCO3 indicates metabolic alkalosis, commonly associated with loss of gastric acid through prolonged vomiting or nasogastric suction. The elevated PaCO2 indicates respiratory compensation. Because the pH remains elevated, compensation is partial. Why the other options are incorrect? B. Respiratory compensation is evident. C. The elevated HCO3 is the primary abnormality. D. The pH has not returned to normal. Question 7. A client has the following ABG results. pH, 7.40. PaCO2, 20 mm of mercury. HCO3, 12 milliequivalent/L. Which interpretation should the nurse make? A. Fully compensated metabolic acidosis. B. Fully compensated respiratory alkalosis. C. Mixed metabolic acidosis and respiratory alkalosis. D. Uncompensated metabolic acidosis. Correct answer, C. Mixed metabolic acidosis and respiratory alkalosis. Rationale. The pH is normal, but both PaCO2 and HCO3 are markedly abnormal. A PaCO2 of 20 indicates respiratory alkalosis, while an HCO3 of 12 indicates metabolic acidosis. In simple metabolic acidosis, the expected compensatory PaCO2 can be estimated using Winter's formula. Expected PaCO2 is almost equal to 1.5 times HCO3 plus 8 plus or minus 2. For HCO3 equals 12. 1.5 times 12 plus 8 is equal to 26 plus or minus 2 mm of mercury. Expected PaCO2 is almost equal to 24 to 28 mm of mercury. The actual PaCO2 is 20, which is lower than expected, indicating an additional primary respiratory alkalosis. Why the other options are incorrect? A. The values indicate two primary disorders rather than simple compensation. B. The low HCO3 cannot be explained by respiratory alkalosis alone. D. The normal pH and markedly low PaCO2 indicate more than uncomplicated metabolic acidosis. Question 8. A client with severe COPD becomes increasingly drowsy. ABG results show pH 7.20, PaCO2 75 mm of mercury, HCO3 29 milliequivalent/L. Which condition should the nurse suspect? A. Acute respiratory acidosis. B. Acute metabolic alkalosis. C. Respiratory alkalosis. D. Metabolic acidosis. Correct answer, A. Acute respiratory acidosis. Rationale. The pH is severely decreased, indicating acidemia. The PaCO2 is markedly elevated, indicating respiratory acidosis. Although HCO3 is slightly elevated, it has not compensated enough to normalize the pH. The client's increasing drowsiness is concerning for CO2 retention and worsening hypercapnia. Why the other options are incorrect? B. Metabolic alkalosis would produce an elevated HCO3 and alkalemic pH. C. Respiratory alkalosis produces a decreased PaCO2 and increased pH. D. Metabolic acidosis would primarily involve a decreased HCO3. Question 9. A client with septic shock has an ABG showing pH 7.25, PaCO2 30 mm of mercury, HCO3 13 milliequivalent/L. Which acid-base disorder is most likely? A. Respiratory acidosis. B. Metabolic acidosis with respiratory compensation. C. Metabolic alkalosis with respiratory compensation. D. Respiratory alkalosis with metabolic compensation. Correct answer, B. Metabolic acidosis with respiratory compensation. Rationale. The low pH indicates acidemia. The HCO3 is low, indicating metabolic acidosis. The low PaCO2 indicates compensatory hyperventilation. Septic shock can cause tissue hypoperfusion and lactic acidosis, producing metabolic acidosis. Why the other options are incorrect? A. Respiratory acidosis requires an elevated PaCO2. C. Metabolic alkalosis requires an elevated HCO3. D. The low HCO3 identifies a primary metabolic disorder. Question 10. A client has the following laboratory values. Na 140 milliequivalent/L. Cl 100 milliequivalent/L. HCO3 10 milliequivalent/L. What is the client's anion gap? A. 20 milliequivalent/L. B. 30 milliequivalent/L. C. 40 milliequivalent/L. D. 50 milliequivalent/L. Correct answer, B. 30 milliequivalent/L. Rationale. The anion gap is calculated as anion gap equals Na minus Cl plus HCO3. Therefore, 140 minus 100 plus 10 equals 30 milliequivalent/L. This is elevated and suggests the presence of unmeasured acids, as seen in conditions such as diabetic ketoacidosis, lactic acidosis, renal failure, and certain poisonings. Why the other options are incorrect? A. The correct calculation produces 30 milliequivalent/L. C. This would result from an incorrect calculation. D. This also overestimates the actual anion gap. Question 11. A client with diabetic ketoacidosis has Na 138 milliequivalent/L. Cl 100 milliequivalent/L. HCO3 12 milliequivalent/L. Which interpretation is correct? A. Normal anion gap. B. Elevated anion gap metabolic acidosis. C. Metabolic alkalosis. D. Respiratory acidosis. Correct answer, B. Elevated anion gap metabolic acidosis. Rationale. Calculate the anion gap. 138 minus 100 plus 12 equals 26 milliequivalent/L. The elevated anion gap indicates the presence of unmeasured anions. In diabetic ketoacidosis, these are primarily ketone bodies, producing high anion gap metabolic acidosis. Why the other options are incorrect? A value of 26 milliequivalent/L is elevated. C. The HCO3 is decreased rather than elevated. D. Respiratory acidosis would have an elevated PaCO2. Question 12. A client has the following ABG results. pH, 7.30. PaCO2, 60 millimeters of mercury. HCO3, 29 milliequivalent/L. Which interpretation is most appropriate? A. Uncompensated respiratory acidosis. B. Partially compensated respiratory acidosis. C. Fully compensated respiratory acidosis. D. Partially compensated metabolic acidosis. Correct answer, B. Partially compensated respiratory acidosis. Rationale. The pH is low, indicating acidemia. The PaCO2 is elevated, identifying respiratory acidosis as the primary disorder. The elevated HCO3 demonstrates renal compensation. Because the pH remains abnormal, the compensation is partial. Why the other options are incorrect? A. The elevated HCO3 shows that compensation has occurred. C. Full compensation requires the pH to return to the normal range. D. The elevated PaCO2, rather than the HCO3, is the primary abnormality. Question 13. A client has the following ABG results. pH, 7.48. PaCO2, 30 millimeters of mercury. HCO3, 21 milliequivalent/L. Which condition is present? A. Partially compensated respiratory alkalosis. B. Uncompensated respiratory alkalosis. C. Partially compensated metabolic alkalosis. D. Fully compensated metabolic acidosis. Correct answer, A. Partially compensated respiratory alkalosis. Rationale. The elevated pH indicates alkalemia. The low PaCO2 identifies respiratory alkalosis. The slightly decreased HCO3 indicates metabolic compensation. Since the pH remains elevated, compensation is incomplete. Why the other options are incorrect? B. The decreased HCO3 demonstrates compensation. C. Metabolic alkalosis would have an elevated HCO3. D. The pH remains alkalotic and the primary abnormality is respiratory. Question 14. A client with renal failure has an ABG. pH, 7.22. PaCO2, 28 millimeters of mercury. HCO3, 12 milliequivalent/L. Which finding should the nurse recognize? A. Metabolic acidosis with respiratory compensation. B. Respiratory alkalosis with metabolic compensation. C. Metabolic alkalosis with respiratory compensation. D. Respiratory acidosis. Correct answer, A. Metabolic acidosis with respiratory compensation. Rationale. The low pH indicates acidemia. The HCO3 is significantly decreased, identifying metabolic acidosis. The decreased PaCO2 indicates compensatory hyperventilation. Renal failure can cause metabolic acidosis because the kidneys cannot adequately excrete hydrogen ions or regenerate bicarbonate. Why the other options are incorrect? B. Respiratory alkalosis would have a decreased PaCO2 as the primary abnormality. C. HCO3 would be elevated in metabolic alkalosis. D. Respiratory acidosis requires an elevated PaCO2. Question 15. A client has an ABG of pH, 7.40. PaCO2, 60 millimeters of mercury. HCO3, 36 milliequivalent/L. How should the nurse interpret these findings? A. Fully compensated respiratory acidosis. B. Fully compensated metabolic alkalosis. C. Mixed respiratory acidosis and metabolic alkalosis. D. Uncompensated respiratory acidosis. Correct answer, C. Mixed respiratory acidosis and metabolic alkalosis. Rationale. The PaCO2 is markedly elevated, indicating respiratory acidosis. The HCO3 is also markedly elevated, indicating metabolic alkalosis. The degree of HCO3 elevation is greater than expected for simple compensation, suggesting a second primary metabolic process. A normal pH does not automatically mean the acid-base status is normal. A normal pH with two markedly abnormal components should raise suspicion for a mixed disorder. Why the other options are incorrect? A. In simple compensated respiratory acidosis, the HCO3 should rise appropriately, but this value is excessively elevated. B. The elevated PaCO2 indicates a respiratory acidifying process. D. Significant metabolic compensation is present. Question 16. A client with severe asthma has pH 7.48, PaCO2 30 mm of mercury, HCO3 22 milliequivalent/L. Later, the client becomes exhausted and confused. A repeat ABG shows pH 7.25, PaCO2 60 mm of mercury, HCO3 25 milliequivalent/L. What does the second ABG most strongly indicate? A. Improvement in respiratory status. B. Development of respiratory acidosis from respiratory muscle fatigue. C. Metabolic alkalosis. D. Normal compensation. Correct answer, B. Development of respiratory acidosis from respiratory muscle fatigue. Rationale. Early in a severe asthma attack, the client often hyperventilates, causing low PaCO2 and respiratory alkalosis. As respiratory muscles become exhausted, ventilation decreases, and CO2 begins to accumulate. The second ABG shows acute respiratory acidosis, which in a deteriorating asthmatic client is a serious warning sign. Why the other options are incorrect? A. Rising PaCO2 and falling pH indicate deterioration. C. HCO3 remains essentially normal. D. The PaCO2 is elevated with acidemia, indicating respiratory acidosis rather than normal compensation. Question 17. A client with prolonged diarrhea has pH 7.29, PaCO2 24 mm of mercury, HCO3 11 milliequivalent/L. Which additional finding would most strongly suggest a mixed acid-base disorder? A. PaCO2 of 26 mm of mercury. B. PaCO2 of 24 mm of mercury. C. PaCO2 of 15 mm of mercury. D. HCO3 of 10 milliequivalent/L. Correct answer, C. PaCO2 of 15 mm of mercury. Rationale. The client has metabolic acidosis. Using Winter's formula. Expected PaCO2 equals 1. 5 times HCO3 plus 8 plus or minus 2. For HCO3 equals 11. 1.5 times 11 plus 8 is equal to 24.5 plus or minus 2. Expected PaCO2 is approximately 22.5 to 26.5 mm of mercury. A PaCO2 of 15 mm of mercury is much lower than expected, indicating an additional primary respiratory alkalosis. Why the other options are incorrect? A. A PaCO2 of 26 falls within the expected compensatory range. B. A PaCO2 of 24 is appropriate compensation. D. A further decrease in HCO3 supports worsening metabolic acidosis but does not by itself prove a mixed respiratory disorder. Question 18. A client with prolonged vomiting has an ABG. pH 7.52. PaCO2 55 mm of mercury. HCO3 42 milliequivalent/L. Which interpretation is most likely? A. Simple metabolic alkalosis with appropriate compensation. B. Metabolic alkalosis with an additional respiratory acidosis. C. Respiratory acidosis with metabolic compensation. D. Mixed metabolic and respiratory alkalosis. Correct answer, B. Metabolic alkalosis with an additional respiratory acidosis. Rationale. The high pH and high HCO3 indicate metabolic alkalosis. For metabolic alkalosis, compensatory PaCO2 generally rises as ventilation decreases. However, a PaCO2 of 55 mm of mercury may be higher than expected depending on the degree of HCO3 elevation, suggesting an additional respiratory acidifying process. The clinical history of vomiting strongly supports metabolic alkalosis as the primary disorder. Why the other options are incorrect? A. The degree of PaCO2 elevation should be assessed against the expected compensatory response. Excessive elevation suggests an additional respiratory disorder. C. The elevated HCO3 and history of vomiting identify a metabolic primary process. D. Respiratory alkalosis would require decreased PaCO2. Question 19. A client presents with severe anxiety and aspirin toxicity is suspected. ABG results show pH 7.48, PaCO2 25 mm of mercury, HCO3 18 milliequivalent/L. Which acid-base disorder should the nurse suspect? A. Simple respiratory alkalosis. B. Simple metabolic acidosis. C. Mixed respiratory alkalosis and metabolic acidosis. D. Mixed respiratory acidosis and metabolic alkalosis. Correct answer, C. Mixed respiratory alkalosis and metabolic acidosis. Rationale. The elevated pH and low PaCO2 indicate respiratory alkalosis. However, the HCO3 is also significantly decreased, indicating metabolic acidosis. Salicylate toxicity classically causes a mixed respiratory alkalosis and metabolic acidosis, making this a high-yield NCLEX finding. Why the other options are incorrect? A. The markedly low HCO3 is more than would be expected from simple acute respiratory alkalosis. B. Metabolic acidosis would generally lower the pH rather than produce this degree of alkalemia. D. Respiratory acidosis requires an elevated PaCO2. Question 20. A client with severe sepsis has pH 7.18, PaCO2 18 mm of mercury, HCO3 7 milliequivalent/L. The nurse should interpret this as A. Simple metabolic acidosis with appropriate compensation. B. Metabolic acidosis with an additional respiratory alkalosis. C. Respiratory alkalosis with metabolic compensation. D. Mixed respiratory acidosis and metabolic alkalosis. Correct answer, B. Metabolic acidosis with an additional respiratory alkalosis. Rationale. The low HCO3 indicates metabolic acidosis. Winter's formula. 1.5 times 7 plus 8 is equal to 18.5 plus or minus 2. Expected PaCO2 is almost equal to 16.5 to 20.5 mm of mercury. The actual PaCO2 of 18 mm of mercury falls within the expected range, so this particular ABG actually represents appropriate respiratory compensation, not an additional respiratory alkalosis. Therefore, the correct interpretation should be A. Simple metabolic acidosis with appropriate compensation. Important correction. This is a deliberately difficult question because the calculated compensation must be checked rather than assumed from the clinical diagnosis. Correct answer, A. Simple metabolic acidosis with appropriate compensation. Why the other options are incorrect? B. An additional respiratory alkalosis would require a PaCO2 lower than the expected compensatory range. C. The primary abnormality is the very low HCO3. D. Respiratory acidosis requires an elevated PaCO2. Question 21. A client has the following ABG. pH 7.10, PaCO2 80 mm of mercury, HCO3 24 milliequivalent/L. Which acid-base disorder is present? A. Acute respiratory acidosis. B. Chronic respiratory acidosis. C. Metabolic acidosis. D. Fully compensated respiratory acidosis. Correct answer, A. Acute respiratory acidosis. Rationale. The pH is severely decreased and PaCO2 is markedly elevated, indicating acute respiratory acidosis. The HCO3 remains normal, suggesting that significant renal compensation has not yet occurred. Why the other options are incorrect? B. Chronic respiratory acidosis should show a more significant elevation in HCO3 due to renal compensation. C. The primary abnormality is the elevated PaCO2. D. The pH is severely abnormal, so the disorder is not fully compensated. Question 22. A client with chronic COPD has pH 7.35, PaCO2 70 mm of mercury, HCO3 38 milliequivalent/L. Which interpretation is most accurate? A. Acute respiratory acidosis. B. Chronic compensated respiratory acidosis. C. Uncompensated metabolic alkalosis. D. Metabolic acidosis with respiratory compensation. Correct answer, B. Chronic compensated respiratory acidosis. Rationale. The PaCO2 is markedly elevated, indicating chronic CO2 retention and respiratory acidosis. The HCO3 is significantly elevated, demonstrating renal compensation. The pH is near the lower end of normal, supporting chronic compensation. Why the other options are incorrect? A. Acute respiratory acidosis would not allow enough time for substantial renal bicarbonate retention. C. The elevated HCO3 represents compensation for respiratory acidosis rather than necessarily a primary metabolic disorder. D. Metabolic acidosis would involve decreased HCO3. Question 23. A client with diabetic ketoacidosis has the following results. pH 7.12, PaCO2 40 mm of mercury, HCO3 12 milliequivalent/L. Which finding is most concerning? A. The PaCO2 is appropriately compensating. B. The client has respiratory alkalosis. C. The PaCO2 is higher than expected for compensation. D. The HCO3 is normal. Correct answer, C. The PaCO2 is higher than expected for compensation. Rationale. The client has metabolic acidosis because HCO3 is low and pH is low. Winter's formula. 1.5 times 12 plus 8 is equal to 26 plus or minus 2. Expected PaCO2 is almost equal to 24 to 28 mm of mercury. The actual PaCO2 is 40 mm of mercury, which is substantially higher than expected. This indicates an additional respiratory acidosis, meaning the client is not ventilating adequately. This is particularly dangerous in DKA because the client should be hyperventilating to eliminate CO2. Why the other options are incorrect? A. A PaCO2 of 40 is not appropriate compensation for an HCO3 of 12. B. Respiratory alkalosis would cause a lower PaCO2. D. The HCO3 is significantly decreased. Question 24. A nurse receives the following ABG results. pH 7.60, PaCO2 20 mm of mercury, HCO3 20 milliequivalent/L. Which assessment finding is most likely? A. Hypoventilation and lethargy. B. Hyperventilation and possible circumaural numbness. C. Kussmaul respirations caused by metabolic acidosis. D. Severe diarrhea. Correct answer, B. Hyperventilation and possible circumaural numbness. Rationale. The elevated pH and decreased PaCO2 indicate respiratory alkalosis, most likely caused by hyperventilation. Respiratory alkalosis can reduce ionized calcium and cause symptoms such as perioral numbness, tingling, dizziness, and muscle cramps. Why the other options are incorrect? A. Hypoventilation causes CO2 retention and respiratory acidosis. C. Kussmaul respirations are associated with metabolic acidosis, especially DKA. D. Severe diarrhea typically causes metabolic acidosis due to bicarbonate loss. Question 25. A critically ill client has the following ABG and electrolyte results. pH, 7.25, PaCO2, 20 mm of mercury, HCO3, 9 milliequivalent/L, Na, 140 milliequivalent/L, Cl, 100 milliequivalent/L. Which interpretation is most accurate? A. Normal anion gap metabolic acidosis with appropriate respiratory compensation. B. High anion gap metabolic acidosis with appropriate respiratory compensation. C. High anion gap metabolic acidosis with an additional respiratory alkalosis. D. Respiratory alkalosis with metabolic compensation. Correct answer, C. High anion gap metabolic acidosis with an additional respiratory alkalosis. Rationale. First, calculate the anion gap. Ag equals Na minus, Cl plus HCO3. Ag equals 140 minus, 100 plus 9. Ag equals 31 milliequivalent/L. This indicates high anion gap metabolic acidosis. Now use Winter's formula. Expected PaCO2 equals 1.5 times HCO3 plus 8 plus or minus 2 is equal to 1.5 times 9 plus 8 equals 21.5 plus or minus 2. Expected PaCO2 is almost equal to 19.5 to 23.5 millimeters of mercury. The actual PaCO2 is 20 millimeters of mercury, which falls within the expected compensatory range. Therefore, there is appropriate respiratory compensation, not an additional respiratory alkalosis. Important correction, based strictly on the numbers, the best answer should therefore be. Correct answer, B. High anion gap metabolic acidosis with appropriate respiratory compensation. Why the other options are incorrect? A. The anion gap is elevated at 31 milliequivalent/L. C. An additional respiratory alkalosis would require the PaCO2 to be below the expected compensatory range. D. The markedly decreased HCO3 and elevated anion gap establish a primary metabolic acidosis. High-yield ABG mastery. Before your exam, remember this sequence. Step 1. Look at the pH. Less than 7.35 equals acidosis. Greater than 7.45 equals alkalosis. Step 2. Look at PaCO2. Greater than 45 equals respiratory acidosis. Less than 35 equals respiratory alkalosis. Step 3. Look at HCO3. Less than 22 equals metabolic acidosis. Greater than 26 equals metabolic alkalosis. Step 4. Determine compensation. Uncompensated, pH abnormal plus 1 system abnormal. Partially compensated, pH abnormal plus both PaCO2 and HCO3 abnormal. Fully compensated, pH returns to 7.35 to 7.45 while PaCO2 and HCO3 remain abnormal. Most important advanced rule. For metabolic acidosis, use Winter's formula. Expected PaCO2 equals 1.5 times HCO3, plus 8 plus or minus 2. Actual PaCO2 within range appropriate compensation. Actual PaCO2 higher than range additional respiratory acidosis. Actual PaCO2 lower than range additional respiratory alkalosis. Anion gap. Ag equals Na minus, Cl plus HCO3. An elevated anion gap suggests accumulation of unmeasured acids, such as N. DKA lactic acidosis renal failure toxic ingestions. Exam trap. A normal pH does not necessarily mean normal acid-base balance. A normal pH with markedly abnormal PaCO2 and HCO3 can indicate a mixed disorder.